Welcome back to the second session of Ask the Experts. We hope that the first session has been very informative, and we're looking forward to covering a wide variety of aspects of questions in the second session here. I think, one of the things that you hear about from patients is that the lens with which they look at maintenance therapy and PARP therapy, for instance, also has to do with like symptoms. So, and the same probably with bevacizumab. So some of the patients that I've seen who have tolerated it incredibly well with very little in the way of symptoms have said, well, the studies were done for 2 years, but like, I want to continue longer. Why can't I continue for longer? And probably the same with the bevacizumab. Do you guys have that happen? And how do you talk to patients about that?
Yeah, I mean, certainly you have had that happen. And I think that one of the caveats is that sometimes more is not better. Mm-hmm. And there is this.
No reference to you, Dr. Moore.
I didn't take it that way.
Not more. More is always better. Dr. Moore is always better. So, but I think that really this is back to personalizing treatment, but also understanding that there may be a downside, and everything we do has an upside and also has a downside. And one of the downsides of PARP inhibitor or long-term or frequent treatment with any type of chemotherapy is risk of developing another type of cancer like a leukemia. And so, we have to be careful about that. Long-term use of Avastin or bevacizumab, depending if a person has had a really radical surgery with bowel involvement, there's a small risk of intestinal perforation. And, there are risks to these drugs. They're not entirely harmless. And I think that that's with any type of treatment that we're offering. And if the side effects from the treatment are worse than not treating, I think that's something to consider as well. And so these are the conversations that I think are important to have on an individual basis with patients.
Yeah, I am. I'm very staunch believer that you stop at 2 years, unless you have evidence of disease, and then you're treating someone. I mean, maintenance is treatment, but you're treating someone. Okay, that's different. But in the SOLO-1 population, which was all advanced stage, so all high risk, but because all ovarian cancer is high risk, this like idea of low risk advanced ovarian cancer is nonsense. They're all high risk, but they're on the lower spectrum, right? So they were mostly patients that got a primary side reduction, not all, but most. They're mostly stage 3. They had very good surgical outcomes. So of the high risk advanced ovarian cancer, it was on the one side of the risk curve. So you have to take that into account. But 50% of them, roughly a little less, have not recurred at 7 years. So why on earth would I have ever, because when we designed the study, I'll tell you, it was in 2012. I was much younger. I wanted to continue it indefinitely because I just really felt like they were all going to progress, and why would I ever take them off? And that's foolish. I'm going to continue it forever until they don't progress. And the FDA said, no way, you can't do that. You're gonna have to stop. And we didn't like that, but we had to do it anyway, and they were right. So you continue it, you would have continued it indefinitely for these patients that never recurred, point 1. Point 2 is that when you look at the curves, and I know that patients don't look at our manuscripts, but sometimes they do, and you'll look at these survival curves. When the slope of the curves in the experimental arm and the control arm, so the olaparib arm and the placebo arm, when they become the same slope, it means the event rates are happening at the same time. And so there's really not any difference in what's happening in each group. That happens about 18 months in on SOLO-1, which indicates that there's really no rationale to continue beyond 2 years in that population. And if you do the same experiment, I haven't done it yet in PAOLA-1 on the updated, so I'll figure that out. But it looked to be about the same in PAOLA, maybe a little bit later. So it just doesn't make sense based on the data that we've seen. And then my point 3, I agree with Dr. Khabele about the risk of leukemia with long-term use. That's a terrible side effect that we don't see a lot of in SOLO-1. because so few of our patients have recurred and gotten any other chemo, which is what causes it, like repetitive chemo. So it's 1%. But it is, if you keep it going, it can happen. But the other thing is that if you keep it going and then someone's tumor progresses while they're taking the PARP, versus you stopped at 2 years and 5 years later it comes back, you're one of the few. Are those different tumors? Like, is that tumor who's not seen anything for 5 years just going to melt away with chemotherapy again and do fine? Whereas the patient whose tumor was exposed continuously to PARP and has grown back on PARP is clearly resistant to PARP, has grown through it. And there's overlapping mechanisms of resistance, not 100%, but they overlap. And so have you just harmed that patient's response to her next line of therapy with that drug? And we need to figure that out. We do not know the answer to that question. And so we need to, and we actually have just proposed a study to look at it in the NRG, because no one knows. But we have to figure that out, because I think we might hurt people by keeping them on something they don't need for too long.
Yeah, I mean, I agree. I explain it to patients, sort of like antibiotics causing drug resistance to an infection. And, you know, my lab is really interested in treating chemotherapy resistant ovarian cancer and finding different combinations and understanding that if we block a certain pathway, these tumors are then pressured, any remaining tumors left are then pressured to activate a different pathway. So being really careful about how we're designing combinations to overcome chemotherapy resistance is also important. And so you limit your options if you've had somebody on prolonged chemotherapy for a long period of time, because the tumors have been adapted to become resistant to multiple pathways.
Yeah, in the recurrent setting, you know, we use things until they stop working.
Yeah,
I'm not even sure in that setting if I agree with that anymore. You know, and if I did we'll probably talk about this, if I do a secondary surgery on a patient who's recurred, you know, with a little bit of disease 5 years later, no ascites, and I take it out and give her chemo again, and then I put her on a PARP, say, the studies continued it forever. The patient's on it for 7 years, and I wonder if you need it that long. There's no answer to that question, but I wonder about it, because our paradigm is, if it's not broken, you know, don't fix it, you know, so just keep treating until, you know, you can't treat anymore for these patients that are otherwise without evidence of disease. Now, if you're treating disease and it's kind of sitting there and smoldering and you know you're doing something, then I clearly am not going to stop something that's working. But in that setting, that's another sort of area where I just don't know that I know what I'm doing sometimes.
There were questions that came up about, you know, concerns about the development of MDS and patients on PARP inhibitors, and, you know, and there was one question that was asking about the 8% risk of MDS development, like in SOLO2, and whether you could predict that, like what are the risk factors for that, or predictors of that. I mean, it's something that, you know, patients, I think, and all of us would love to know. Yeah,
I was really fortunate to be a part of a project on this, so published a little bit on it. So treatment, they're called treatment-related myeloid neoplasms. Treatment-related myeloid neoplasms. We just say AML MDS, but there's a whole spectrum of these dyscrasias that happen. And so there's a bunch of things that fall under this rubric. We just have to, it's much more complicated than just AML MDS. And you do see an increase in them across the board in solid tumors. There's an interesting review paper out a few years ago that demonstrates that, and it very much is correlated with use of platinum, which I'm not saying the PARP is innocent. I'm coming back to that, but it's very much related to subsequent, like use of platinum, the rise of platinum across a lot of solid tumors, and repeat use of platinum, and probably other things. So if you're exposed to multiple lines of therapy that's DNA damaging, it can lead to some of these dyscrasias, even if you've never had a PARP. I mean, we saw these treatment-related myeloid neoplasms, you know, a long time ago. We'd see them, but you could like count on one hand the amount of time you've seen them. Have I seen them more? Yes. Why is that? One is we are using PARP inhibitors, and PARP inhibitors are another thing that contribute to that risk. They're not the cause, but they contribute to the risk. Two, we're keeping patients alive longer and they're getting more stuff. So the more lines of therapy you're exposed to, the more your bone marrow is sort of damaged. And at some point, you just cross some line where the bone marrow is just done. And it just converts to these, either pre-malignant or malignant phenotypes that are very difficult to treat, but not impossible. And so it's a part of the story, but it's not the entire story. And then there is a baseline risk. And very smart people in heme malignancies have looked into this. There's these CHIP mutations, clonal mutations of indeterminate potential. I think I'm misstating that identify patients at higher risk, but they're not causal in and of themselves. And not everybody that has one gets a subsequent AML MDS picture. So it's been very confusing. I think there's some correlation, for patients that had like very deep myelosuppression on PARP inhibitors, like, anemia is a class effect. You see it in about a quarter of patients will need a transfusion, and then you dose modify and it shouldn't happen again. And that's fine. But patients that like have repetitive drops, like despite the dose modifications, are just chronically getting the anemia or have other big drops, your attendance should go up a little bit about pushing the PARP potentially in that setting, because that may be someone that has some inherent baseline risk that you're just born with. And then we may tip them over earlier than not. But even that is not proven. And, it's just sort of, when I see that, I'm like, how much benefit am I going to get from the PARP? Is this a BRCA? I'm going to stop as soon as I can. If it's like I'm using it in homologous recombination test negative, I'm not going to probably use the PARP. I'm probably going to switch because I'm worried about that patient's bone marrow. But it's like a gut. And also, I think this is hard for the majority of our providers are in community settings, smaller practices, and they don't have like surrounding experts like I have here and you both have. But like I walked down the hall, actually right before you got on the call, I was talking to my buddy who's the leukemia transplant lead. He helps me with all these patients. He can do bone marrow the same day I call him on the patient. So I have a lot of help here, as do most in academic world, with just having really smart advisors kind of right down the hall from us. But that's really difficult for some of our colleagues that don't have that easy access to a leukemia specialist or a AML MDS specialist, and they have to get referred, and you don't want to waste their time, and if you're just a little worried. So I don't know, it's just it's hard, I think, for folks that aren't surrounded by resources like we tend to be in the ivory tower.
Dr. Khabele, one of the questions that came through, and I think that this is a question that kind of comes up not infrequently, is if you are non-HRD positive, do you offer PARP maintenance therapy to your patients that fall into that class?
I mean, this is a challenge because this is the stuff that I study in my lab, and I am a little bit nervous about it. There are different types of PARP inhibitors with different levels of potency and slightly different mechanisms of PARP trapping that actually lead to cell death, DNA damage and cell death. And that's sort of a generic mechanism across the board. But when we look at the data, the PARP inhibitors work best in patients who have tumors or germline mutations with the BRCA or the HRD kind of molecular profile. And so this issue of drug resistance and all of this stuff really becomes even more important in the setting of a non-BRCA mutation and a non-HRD tumor, in my mind. And so, for maintenance, then, I probably would then, be more likely to offer Avastin or bevacizumab a pathway rather than the PARP inhibitor pathway. But of course, it's something that's FDA approved for me to offer it to patients. But these are the really challenging and nuanced conversations that I end up having with patients. This is where that somatic testing is really important. My lab focuses on about a group of chemotherapy resistant tumors that have amplifications or too many copies of a gene called cyclin E. And so there are new drugs coming down the pike that may be more successful in treating those patients, or perhaps could be used in the future for maintenance therapy in those patients. So it's not an easy answer. There are lots of clinical trials looking at this that Dr. Moore has been involved in, but I don't automatically offer those patients a PARP inhibitor in that setting. That's my personal practice.
Dr. Moore, anything to?
I mean, I think it's as we said, it's an option. I think there's a lot of clinical equipoise here around this group that's very ill-defined. Like, these tests that we're using to make these decisions are very imperfect, to say the least. So, you've made the decision to use bevacizumab sometimes before you know the results of the test, especially if you get the test at the time of interval surgery. Like, you've already made that decision for bevacizumab, and I don't stop bevacizumab. And so if I've started bevacizumab and someone's HRD test negative, I might just continue the bevacizumab. The caveat to that is, if someone's getting neoadjuvant, for example, and I've started bevacizumab and they're responding beautifully, it's just melting away. Well, I don't care what the test says. Their tumor has got some homologous recombination deficiency because it's responding to platinum. So then I'm confused. And sometimes I like to use the Powell regimen if I can get away with it, which is off-label. I'm going to say off-label, not FDA approved. But sometimes I like to try and sneak it in because their tumor is showing me that it has some loss of homologous recombination deficiency. But the same is true the other way. You'll get these tumors back that say they're homologous recombination deficient or LOH high, depending on what test you send. And they're just like, the C125 is kind of slowly coming down, and there's still a lot of disease at the time of interval, and it's not got a great chemo response score. I mean, you're going to tell me that monotherapy PARP is going to hold that? It's not. I'm going to add Bev there, actually, to be honest. So I think it's just the context, and there's just a lot we don't know. But we need trials for these tumors that are truly, when we say homologous recombination, what we mean by that is that's the process by which DNA repairs as double strand breaks. And so if you can't do that well in your tumor, it's really susceptible to drugs that damage DNA, like carboplatin, PARP inhibitors, and Doxil, for example. If the tumor is really good at fixing its DNA, homologous recombination proficient, it's really good at it. It just lives through everything you throw at it.
Yeah. And those are the tumors that I'm talking about. So the nuance that you're describing is if there's a defect in the homologous recombination pathway, they're HRD, HR deficient, or a BRCA mutation, well, then the PARP, the BRCA mutation, you do a PARP single agent. But if there's HRD and you have them on bevacizumab, you would add the PARP inhibitor, clearly.
Yep.
But what I was speaking of is the HR proficient, these tumors that
no, I agree with you.
That are very, very efficient in repairing DNA damage and don't respond as well. Now, what we do know just generically is that 80% of high-grade serous ovarian cancer, 70 to 80%, will have some sort of response to platinum-based chemotherapy at the get-go, as frontline treatment. But what about those 20%? The 20% of tumors that don't have that initial response? And that, I think, is a space where we don't really understand as much as we really need to get frontline therapy to be adjusted beyond platinum-based or typical Taxol carbo.
Let's segue a little bit into talking about, quote unquote, platinum resistant disease, because this is an exciting space also in terms of agents that are coming out.
Yeah.
You guys want to talk a little bit about that? I think we talked a little bit about like folate receptor antagonists and some of the studies around that, but what are you all excited about in addition to that, for instance, in the platinum resistant space?
There's a lot. I mean, there's a lot of trials right now. They've kind of fall into 3-ish broad categories. There are things that are trying to combine with paclitaxel. So paclitaxel, weekly paclitaxel is probably our most effective monotherapy agent. Response rates are north of 25%, which I know to our patients does not sound very high, but that's pretty high in this space. It could be even higher depending on the line of therapy. So there's a lot of interest in combining things with that. So there's a number of trials. Aravive has a really interesting Gas6 ligand that they have in combination with weekly paclitaxel. That's a very interesting drug because it has no single agent activity, does not work by itself. It's really made to synergize with certain agents. Weekly paclitaxel, it holds the taxane inside the cell. It prevents that kind of efflux pump that's a mechanism of resistance. And so, but thereby the hypothesis that if it holds it in, it's going to kill more of the cancer cells. And so that's a trial that's open and accruing right now. That's sort of one of the weekly paclitaxel backbone studies I'm excited about. I'm excited about all the antibody drug conjugates. I think they're amazing. And not all of them will work, but many of them will. And you think, our listeners can think about them kind of like Trojan horses, where you target the front door of the cancer cell. It has a protein that, lets it in. So you target that protein, and there's a bunch of these proteins. And then the protein basically opens the door and sucks the whole molecule in. And then the molecule releases this chemo inside the cancer cell that's very, very potent. It's not Taxol or Doxil. It's totally different. Really potent. Kills the cancer cell and then surrounding cells. So it's like Trojan horse sneak the army in. So I like that. And then the third category is immunotherapy, which has been largely disappointing in ovary cancer. The Keytrudas and Opdivos, which are fantastic drugs, checkpoint inhibitors. Just these, I think that's what people always come in because they see the commercials.
Yeah.
Chance to live longer, and you're like, yes, for lung cancer. They've been disappointing for us. But there are new drugs that are trying to basically either give you an army of activated T cells to fight your cancer, kind of grown outside your body. And so that's sort of engineered cellular therapeutics. And there's a study that's about to launch in ovary there. In ovary right now, the study is called Surpass-1. And then there's a whole bunch of these T cell receptor engagers and activators that try to make your body inside you make more activated T cells. T cells are the fighter jets to activate against a protein that's on your tumor, like MUC16, which is a CA125 protein, for example. So there's these two strategies, both trying to get the immune response like fired up against the cancer. And I'm pretty excited about both of those. I'm kind of waiting to see what happens, but those would be my top 3 groups.
Yeah. And the immunotherapy story is really, truly, it really is disappointing and frustrating. But I think that some of the things that we think about from a laboratory standpoint is, even if you have immune cells that are kind of revved up and they're surrounding the tumor, you have to have proteins and other elements that are released by your immune cells to actually kill the tumor cells themselves. And so
neoantigens and
yeah, but not just that, like there's granzyme, and there are differently enzymes and proteins that are released by T cells to actually do the killing, and macrophages that kind of chomp up the tumor cells. And so all these immune cells may be in the microenvironment of the tumors, but they may not be functional. So
Yeah.
even if you're doing things to kind of bring them in and activate them, you need that last bit. So there's multiple places where we can try to activate the immune system and harness the power of the immune system beyond the current checkpoint inhibitors that we have available.
Yeah.
And then there's other, like more sophisticated, like CAR T therapy and sort of transplant therapies that are still in clinical trials for solid tumors like ovarian cancer, but it's the same sort of thing to sort of to attack tumor cells and using the immune system.
Certainly an opportunity to look at some of the other immune cells as well. I mean, NK cells and some of the cytokine pathways and things like that. So you're right. I mean, checkpoint inhibitors have been have not shown the promise that was originally thought, but gives people the opportunity to ask additional questions about what might lead to change. Yeah,
we just heard it as ESMO, another readout of the Adelante study, which was atezolizumab, bevacizumab, so an immune checkpoint inhibitor and Avastin versus Avastin alone in the platinum sensitive space. And that's surprising because we saw my frontline study wasn't positive with that same combination. For some reason, I was still hopeful that the study in the second line would be positive, and it was not. As the European investigator said, alas, it is not positive. So I think that, but we have 4 frontline studies where we're combining immune checkpoint inhibitors. Every company has a different one, plus PARP with or without Avastin or bevacizumab. So Dr. Khabele, what do you think? Is PARP going to fix it? Say yes.
I'm not sure. I mean, there's a possibility of uncovering neoantigens that could then make the checkpoint inhibitor work better. And but I think one thing that was mentioned probably at our last NRG GOG meeting is we have to be really mindful of the patient, right? How many combinations are we going to offer? How many, because then we're accumulating toxicities. Each individual drug has its own list of toxicities, and then you're combining it and potentially increasing side effects in different ways. So I think, again, this is a big plug for translational research to make sure that we have the biological and kind of molecular rationale for why we're doing this. And I think that there is a rationale for using the PARP inhibitor to try to cause some DNA damage to uncover neoantigens to make the immunotherapy work better. But I think that there's still more work to do, and I'm hopeful, but I don't know that that's going to be the answer.
We'll see next year.
Yes,
it'll be a big year for us. 2023. A lot of studies read now.
One question that came up was, getting access to clinical trials, and what do you do if your oncologist is not necessarily aware of clinical trials? How do you get access to some of the information about that? Do you have any tips or recommendations?
That's such a good question, and just sort of underlies a big problem that we have here. There's just a lot of inequity in access to things. You can only get on trials if trials are offered at your site, and why a trial is open here or there depends on a lot of things, but often excludes sort of large swaths of the population. And we see that reflected in our accrual, which is mostly white people. So that's changing. We will see some studies reported out with more representative demographics in cervical cancer and endometrial cancer, but ovary is still lagging. So this is a problem, and I don't know that I have an easy answer. I think that there are some things. I think number one to know is that there's finally a lot of attention with real intent and resourcing behind it to start changing access to trials nationwide. So there is change coming for patients who are interested in having clinical trial opinions. A lot of centers, I think on Friday this week, I think I'm doing 4 virtual visits, consults with people in like one in Alaska and one in, Michigan, with my clinical trial team, and we kind of go through their records and we talk to them about trials, and we do remote consenting when we can for pre-screening, so they don't come here for no reason. But a lot of places will do that, but not all. Some states have rules about, you can't do these if you don't have a medical license in that state, which is an unnecessary burden. Or if you're not an established patient, you can't be seen. So sometimes doctors really do want to help you, and we're just locked in by sort of ridiculous laws. So you can try and find people to do a consult that way, and get a second opinion. And then we can often help find the study closer to you, once you're sort of in the door. I think that's sort of my one recommendation, until we really get the trials out of the big centers, and out into the community, where they can be. And there's many examples of successful community practices that do trials incredibly well. Sarah Cannon is one of them. They're not housed at the center place in Nashville. They're all over the US. So this can be done. It's just going to take time. But until then, I think you've just got to reach out for second opinions at some of the bigger centers that allow remote consults. Now I'm thinking about it, we should put a list together for some of the advocacy groups, so that patients have that access list. I just thought of that.
I totally agree with you, Dr. Moore, and I spent a lot of time with patient advocates to really talk about self-advocacy and, trying to find physicians that you're comfortable with. If somebody asks me if they want a second opinion somewhere, I'm happy for them to seek it. I don't take it personally. And I think it's really important for us to encourage people to seek opinions. If there's a clinical trial that's available at another center that we don't have available, I think it's important to provide that information to the patient. And if the physician is not aware or doesn't have access to that information, then you can request a second opinion. Online, clinicaltrials.gov is just an online reference for different types of clinical trials. But then, of course, the Ovarian Cancer Research Alliance and Foundation for Women's Cancer, these are reputable places you can go online to sort of get additional information about your cancers, and then get additional information about sites for treatment. But I think we can do a better job in letting people know what's available as well as physicians ourselves.
Yeah,
very good question.
In the last couple of minutes that we have, I just wanted to touch on rare ovarian cancers. I just want to highlight the fact that Dr. Jubilee Brown is going to be doing a session on rare tumors, so there will be much more information there. But what all is exciting in the world of rare cancers, rare ovarian cancers?
The fact that we're finally studying them is quite exciting to me. I think, and I always say that as a joke, but it's not actually a joke. So through the cooperative group, through the NCI, where we have the potential to open studies, really broadly, 600 sites, because everyone can just activate. You don't have to have a site visit. All the things you have to go through to open at your site, you can just open it, through the group. And so that allows us to do rare tumor studies very well, because pharmaceutical companies will do it in some cases, but they're not going to open 600 sites to find the 50, ARID 1A mutated, clear cell, non-endometriosis tumors that might respond to temazostat, for example. Said that wrong. But the NCI will, and that's how we do studies in rare tumors. So we're doing a huge study right now for women with low-grade ovarian cancer, which is only 10% of all ovarian cancers. And as I said earlier, it's not really ovary cancer; it's a totally different subset. Needs a different name, because you may be able to treat a hormone with endocrine therapy. Mm-hmm. And so we're running as you know, a study. It's open and accruing for women that are newly diagnosed with advanced low-grade serous ovarian cancer, can be randomized to get an endocrine therapy called letrozole versus standard of care chemo, like we always use, followed by letrozole. The question is, do you need chemo at all, or can you omit chemo? It's an incredibly important study.
Very clinically relevant.
It's very clinically relevant. It's going to be practice changing. It's going to be like the surgery question, because half the world that's already early adopters is going to be like, haha, I was right, or oh crap, I need to go back to chemo, because people were already using this based on retrospective data. So we're doing a trial appropriately so we can prove it or not. And it's accruing great. Like, it's accruing ahead of schedule, because we can do these studies. You know, we can do studies of, like, was joking about the clear cell cancer, accrued in a minute, 30 patients with a biomarker. It was opened and closed in, like, not a minute, but 2 months. Come on. We can do these rare tumor studies through the NCI, and we're finally doing them quickly. And that's going to move drugs into availability for patients who need them. And so I'm just excited about that we're finally doing these trials and asking the good questions, because otherwise you're just left as a clinician, you kind of just making stuff up. Well, I think maybe an mTOR inhibitor might work here, and so I'm going to just try it. No one wants your doctor just to be like winging it. You want some data. So I'm excited we're studying them. That's my excitement.
But also, I think I'm really so grateful to every single patient who has signed up for a clinical trial. And, one of the things, I was talking to somebody the other day who's a pediatric oncologist, and I wish that we could move towards their model as adults. So if you have a childhood cancer, 90% of those children go on some sort of clinical trial, which I think has really led to rapid advances in treatment of childhood cancers, which are not that common. So I think with rare cancers, rare gynecological cancers, including ovarian cancer, that model of having multiple sites available to open these really important trials, and if you have a diagnosis of a rare cancer, to have that as part of your standard of care, to be enrolled in one of these trials, would be game changing. And that's like a slightly different model from what we're used to for treating adult cancers, but particularly for rare tumor types. I think that would be really important. The fact that this is, we have evidence that it's working, having these quick accruals lets us know that it's possible to do this.
And there's new mechanisms. No, they're not new, actually. But I think we're going to figure out how to utilize them better for rare tumors outside the cooperative groups, these just-in-time site activations. Because if you're a site and maybe you see one neuroendocrine cervical cancer every 2 years, you're not likely to open a trial, because it costs money to open trials. I think you just have to understand that we don't make a lot of money on trials. You usually can lose money, especially if you don't accrue. And so people are real reluctant to open rare tumor studies because they may not ever find a patient. But especially for the molecularly targeted ones now, there's this mechanism where you can kind of do some of the work to activate it. And then when you find a patient who has the marker, or they get referred to your site, you can pop open the rest of it. And they do these really rapid site activations so the patient can have access, and then your site is activated and you can move. So many studies are moving towards this for a particular, there's a lot of niche cancer development right now in a certain biomarker, like the HER2 I talked about, TSC1, TSC2 as a marker for nab-sirolimus. That's an important one for us. 4% of endometrial has TSC1 or TSC2, and that drug may be transformational for our patients, but 4%. So you're going to open that everywhere, or you're going to wait till you find one, and then it'd be nice if you could just pop it open in 4 weeks for that patient. So with lots of next gen sequencing being done, the companies are now offering this sort of, they're tracking patients with these molecules and calling the site going, hey, you've got a TSC2. Do you have the ADDI study open, as one example? And you can be like, no, but I need it, and get it going. But I think that we're being much more proactive with trying to get studies to patients wherever they are, and trying to overcome barriers to, if you're being treated in, Idaho, and you're not near a major medical center, but you have this mutation, your site can activate it with this mechanism. So I'm pretty encouraged by that. It's by no means easy peasy and worked out, but I feel like we're on the wave of this sort of model. And I'm excited to see where that goes. Not quite fully functional yet, but getting there. So I think that's going to be helpful.
The other plea is for tissue samples during these clinical trials, if possible, biomarkers to help us understand better response and resistance, because you know, we're building on prior knowledge and data. So if somebody has an exceptional response to a new drug, we want to know why. If somebody doesn't respond at all, we want to know why. And sometimes the blood markers or tissue are really important in helping us determine that.
Absolutely.
That's fantastic. Well, I think our time is up for this session, but this has been a fantastic session. I hope the audience listening has enjoyed it as much as I have. I think back, you know, I reflect back on the time when I was a fellow. I won't say how many years ago now, but in what we did in, you know, early out in practice, and it was just so, you know, monotherapy, mono treatment. It didn't have the color that it has now, or the depth that it has now, and the level of excitement that it has now. And it's just so wonderful to see people differentiating and really diving deep into the translational aspects of what we do, and the you know, the clinical research and the surgical outcomes, and the depth and breadth is just incredible. And so I think it's just really an exciting time. So you guys are the perfect examples of how that moves forward. So I just really want to thank you for your time, and really encourage people to look at the other sessions that are there. There's some incredible sessions on the agenda. So thank you very much. Any last words?
Thank
from
you.
either of you?
Thank you so much. This has been really great.
Yeah, thank you. I think it's an exciting time. I agree with you. We're finally, I think, starting to individualize more, and it's gonna be great for our patients until we can cure them, all of them. So that's the goal. Prevention is the goal.
Prevention
then
and
cure.
yeah, and then
While we
highlighting
continue
areas
developing.
that we need to
prevention
advocate
first.
for.
Yes, yes,
So,
yes. The ultimate goal.
yes.
Make us irrelevant. That's fine.
Exactly.
We all Dineo has a full job that she could do without cancer.
That's right.
Her job is secure. It's a chair.
In many ways.
I don't think so, but thank you. Really delightful being on with both of you, and I share the excitement, and I hope patients and patient advocates can see the progress we've made in the past few years, and but there's still so much more to do. So yeah,
It's a partnership.
yes.
Well, thank you both so much. I'll see you soon.